welcome to PCR London Valves 2025. My name is Joanna Wykrzykowska. I'm one of the interventional cardiologists in Groningen in the medical center in the Netherlands. And it is my pleasure and honor to be joined by Professor Hélène Eltchaninoff from Rouen, who of course has done many trials on TAVI. And we'll discuss today small annuli. What are the challenges in treating patients with small annuli? So let's start with the definition, Hélène. What is a small annulus and how frequently is this problematic?
So several definitions were available more recently, like it can be based on echo, it can be based on CT or on surgical bioprosthesis diameter, but in fact now it's quite clear that it's CT based, and the small annulus is defined by a valve area which is less than 400 or 430 millimeters square. It's quite prevalent because it affects, it's observed in 25% of the candidates for TAVI and in 75% of women. So it's a woman feature which is very common.
Yeah, so in several trials we've shown indeed that women have perhaps better results with TAVR versus SAVR by small annuli. But it also applies to men with the same anatomy. What are some of the challenges of the small annulus? Is it just the size or is it something else?
Yes, there are challenges because the gradient can be higher. Mm-hmm. And variable with the platform, so this is something which has to be discussed. And also a small annulus is often associated with smaller aortic root, mm-hmm. smaller LVOT, a smaller membranous septum, a lower rate of the coronary ostia, and smaller sinuses. So it's associated with several challenges, as you say. And we can start at least with the first challenge, which is there a hemodynamic challenge? Is there something about the residual gradient after TAVI in small annuli?
Yeah, absolutely. So we observe a bit higher gradients, especially with balloon expandable platforms. But the question is always, is it real? Is it an artifact of echo measurements that we make? Most of the time when the patient leaves the cath lab and we have measured invasive gradients across the platforms, it's fairly low, or we wouldn't actually send the patient back. And we know also from your own trials as well that at longer-term follow-up, it does not really, having a bit higher gradient with one platform versus the other does not translate into clinical outcomes. Of course, this is one measurement, one number, one gradient, I think, at the end of the procedure. And the question is what happens to the gradient over a year. And that sometimes does have prognostic information and if there's a rapid change. So you mentioned some of the other features. So short membranous septum, low coronaries. How do you address these issues in the cath lab? Do you adjust the valve position, lower, higher? Do you adjust the valve platform depending on what you see on the CT scan?
I think in a small annuli, as in any patient, it's very important to take into consideration all the parameters because you need, of course, to have the best hemodynamic result as you can, but you need also to avoid the complications which can be fatal, like the risk of coronary occlusion, the risk of pacemaker, of paravalvular leak. So all these have to be taken together, and then you select the valve you consider the best for considering all these aspects. Of course, balloon expandable have the advantage of the coronary access, the feasibility of implantation, and the lower rate of pacemaker and paravalvular leakage. Self-expandable have other advantages. So I think the most important is that hemodynamic, like lower gradient by between 10 or 15, is only one of these parameters, and really it's the selection has to be done on all the parameters.
It gets tricky because a lot of women have this paradoxical low flow, low gradient state with very small hypertrophied cavities, and their gradient a priori are low, and it's sometimes very difficult to assess what happens to the gradient and what it means. Do you think that particularly in that patient population, achieving the lowest possible gradient is most important?
The gradient depends on the flow, as you say, so it's very difficult because if you have a very low gradient, it can be related to a low flow and a poor condition, and they can have a worse outcome. In fact, so the gradient is not the only parameter because. Of course, it's good to have a gradient which is not too low because it is worse, but not too high also because if you finish with a gradient around 20, and if you use the contemporary definition of dysfunction, you will reach more fastly the 21 of dysfunction. So I think it's a subject which we have many remaining questions on this aspect because the hemodynamics are quite complicated because you have the gradient, you have the area, you have the flow, and also is it really a problem to have a gradient of 20 when we know that aortic stenosis 20 is nothing? So I think there is a lot of research to do on this subject.
Absolutely, and I think based on the research, we may have to revise our criteria and produce VARC-4 criteria, indeed. Do you already, if you treat a younger female or male patient with small annulus, do you also try to look into the future and try to decide which platform will I use first, which one will I use second to ensure feasibility of revalving?
Yes, it becomes more and more complicated because that's true that we have lower risk patients who are very often younger. And that's true that we should pay a lot of attention on the first device to be able to know what to choose if there is a reintervention which is needed in the future. It's not always possible because you have also to take into consideration the risk of complications. So it's a kind of balance, but for sure you have to think about it, the first procedure, what would be the best for the second one, for sure.
Wonderful. Thank you so much, Hélène. I think we covered lots of topics. Hopefully you got from this that small annuli defined based on the CT sizing are actually quite prevalent in both males and females, that they require good technique and proper valve deployment and achieving best results at the index procedure, and that we have still quite a bit to learn about this patient population. So thank you.